Good afternoon. Welcome to today's TASA webinar, Medical Errors and Human Factors. The medical profession touches just about everyone's life at one time or another. This $2.5 trillion industry includes almost 6,000 establishments that vary in size, staffing, patterns, and organizational structure. For example, although hospitals constitute only 1% of establishments, they employ 35% of the workers. Consequently, the healthcare industry has a wide range of stakeholders, including the patient, medical services provider, hospitals, insurance companies, third-party administrators, government, equipment manufacturers, drug manufacturers, pharmacies, pharmacists, and certifying boards, to name some of those involved. Reports indicate that in 2008, there were over 6.3 million measurable medical injuries. 1.5 million of those were associated with medical error. This resulted in $19.5 billion in extra costs to the healthcare system. While other industries have long ago recognized the need to develop a comprehensive approach to identifying and preventing future errors by targeting the root cause, the complexity of the medical industry has made it more difficult to implement uniform procedures. In addition, as technology has advanced, the quality control and patient safety processes have not always kept up with the increasingly complex nature of today's healthcare system. During today's webinar, our presenters will cover the following: what medical error is and why it is important to you, the role of human factors experts in medical errors, two main types of medical errors, the components of a patient care team, 5 key principles of an effective patient care team, the 3 major outcomes of an effective patient care team, the use of evidence-based framework to optimize team performance, why the use of closed-loop communication protocols is important, what can be learned from other industries, barriers to an effective patient care team, the 2-challenge rule and why it is important, and the patient's role in reducing medical errors. The presenters for today's webinar are William Nelson and Mark Heidebrecht. Mr. Nelson has over 30 years of experience in ergonomics, biomechanics, human factors principles. Mr. Nelson's expertise and areas of specialization include product liability, personal injury, premises liability, and accident reconstruction. He has been directly involved with the commercialization of emerging technologies such as holography, lasers, acoustic reflectometry, and electronics. Of special interest to Mr. Nelson are the unintended consequences from the use of emerging technologies in today's multicultural society. Of particular interest is the emerging research in the area of driver distraction, sports injuries, and medical errors. Mr. Nelson has been a presenter at national and international conferences and has over 18 years of litigation support experience as an expert witness throughout the U.S. municipal, state, and federal court, as well as has experience with the Daubert hearing process. Mark Heidebrecht has over 20 years of experience in research and application of ergonomics, biomechanics, physiology, and human factors principles. As a board-certified ergonomics human factors professional, Mr. Heidebrecht includes the following in his areas of specialization: product liability, personal injury, premises liability, and accident reconstruction. Areas of special interest include injury causation, driver distraction, helmets and concussions, and medical errors. Mr. Heidebrecht develops and teaches a preparation course for professionals pursuing certification in human factors and ergonomics. He has testified as an expert before OSHA regarding the proposed ergonomic standards and was asked to present at the National Academy of Sciences regarding the effectiveness of ergonomic interventions and the early identification of certain disorders. Mark has been involved in the product development and commercialization of medical products using emerging technologies. He's also presented to and consulted with numerous corporate clients, governments, and educational and medical institutions throughout the United States. Mark has given litigation support as an expert witness throughout the U.S. in municipal, state, and federal court, as well as with Daubert hearing process. If you have a question that pertains to today's presentation, we ask that you use the chat feature or the Q&A feature, which are found on the right-hand side of the screen. I've indicated the location with the red pointer. Will and Mark will do their best to answer your questions during the presentation. Tomorrow morning, I'll send out an email with a link to the archived recording of the webinar, and we do ask that you take time to fill out the survey that will appear on your screen after the webinar is over. I now invite you to sit back, relax, and enjoy. I'm going to turn our presentation over to our distinguished guests, Will Nelson and Mark Heidebrecht. Will and Mark, it is all yours.
Thank you, Matt. This is Will Nelson. I also have with me Mark Heidebrecht, and we appreciate the opportunity and appreciate you taking the time today for your busy schedules, regardless of whether it is still morning or early afternoon, depending on where you're located. Today's presentation, just a couple things I wanted to cover with you. It's informal, and so as Matt had mentioned, if there's questions that you have as we go through the presentation, please feel free to, I think it's through your computer screen, to chat to us, and we will pick up those questions. We also are having a break in the middle of the presentation for Q&A, and then there will also be time at the end of the presentation for additional Q&A. So this is for your benefit, and we are here to help you in any way possible. We're taking a very complex topic today, medical errors, that would generally be in a 3-day seminar and condensing that down to a 1-hour presentation. So obviously we're covering a lot of material in a very short period of time and are just hitting the highlights. In some cases, we may raise more questions today than actually answers for you. So I want you to know, though, that we're available to answer any questions throughout or following after today's presentation, too. We intentionally titled the presentation, Medical Errors to Err is Human, with a question mark at the end of that. And the reason for this is that we do not believe that to err is human is the norm. We hope that we'll help you today to understand as we go through the presentation of why we believe that errors do not have to necessarily be involved in a system, especially in the healthcare profession. As Matt had mentioned, the two of us, I'm the one on the left. Mark, the handsome one, is on the right here. When we exchange on who is talking, we'll try to be clear so that it's clear to you about who is giving the information about the different slides. So we'll be working together on that. Humantex has been working with TASA for almost 15 years and is a very good partner to work with, and again, we appreciate the opportunity to present today. Just an overview of what we'll be covering today. We'll start off with some statistics about medical injuries and errors, the difference between medical injuries and errors, types of medical errors, a human factors model that analyzes errors, and then a couple of system approaches we will go through, and an example. Just start with a quick overview of some of the statistics here. 6.3 medical injuries were recorded in 2008. This represents approximately 7% of admissions to inpatient facilities. It's the 5th leading cause of death in the United States, with some studies indicating up to 98,000 deaths annually. So you can see there, it's a very significant problem. The medical injuries has resulted in 1.5 million medical errors that has led to, of those 6.3 million medical injuries, 1.5 million are attributed to actual medical errors themselves, and has resulted in 10 million excess days missed from short-term disability. These next two slides, I don't want to go into detail with you. The purpose of these two slides, and I'm going to use a pointer here, you look here where it talks about the percent of injuries that are errors, what I want to point out is these areas that have greater than 90% of the injuries that are directly attributable to medical errors. You can see that each one of these, there's infection due to central venous catheter, infection following infusion, injection, transfusion, vaccination, and complications from gastrostomy infection. All three of those have to do with infections. And then the total cost per error, as you can see, is very expensive. And then again on this slide, I want to just point out again under where it talks about percent of injuries that are errors. You have pressure ulcers, post-operative infection, and again, infection and infection. So you can see that infection, as you may or may not know, is a very important medical error that occurs in the hospitals today. Okay, the total cost per error is estimated about $13,000, which results in over $19.5 billion in total cost. Of that, $17 billion is direct medical cost. Most other costs of medical errors, such as pain and suffering, are not measurable from the databases, as well as it does not include malpractice costs or insurance payments as part of that. So it's a very conservative number. Obviously, it's a large number, and one that we feel is much higher than it needs to be. As mentioned in the introduction, the healthcare system process is a very complex system with many stakeholders. I won't go through each one of these, but even in addition to these that are listed here that go into the patient care, we also have such ancillary areas as maintenance, tech support, IT department, the engineering department, and the admissions area, as well as many other areas. So a complex system of this, without taking a systems analysis, which we'll talk about in a little bit, does not allow you to really get a handle on the various areas of potential error within the system itself. So let's talk about what is a medical error. This is a definition that actually is from the Society of Actuaries Health section. It talks about a preventable adverse outcome of medical care that is a result of improper medical management rather than a progression of an illness due to lack of care. The difference between those, and we'll talk about in a little bit, is a mistake of commission versus a mistake of omission. We actually, when we are looking at medical error here at Humatech, we actually include both of those as medical errors, and we'll talk a little bit more about that as we go through this and why we do that. The role of human error. This is another quote. This one is actually from the book To Err is Human, which was a groundbreaking book. One of the greatest contributors to accidents in any industry, including healthcare, is human error. However, saying that an accident is due to human error is not the same as assigning blame, because most human errors are induced by system failures. Humans commit errors for a variety of known and complicated reasons. We feel this is a very good quote. However, we also make a very important distinction between accidents and incidents, and we do not use the word accidents relative to human errors. We believe that the word accidents involves, or it implies to people that it is a non-controllable or manageable event, such things as acts of God. We use the term incidents, which provides a more defined explanation of exactly what we're talking about here, and that is that it is something that is manageable. We use a process very simply that you can't quantify something if you can't measure it. You can't manage something if you can't quantify it. So we take the approach of looking at very basic data is critical to being able to prevent medical errors. It has to be something that we can measure in order for us to really get to the root cause of it. We'll talk a little bit more about that coming up too. Let's talk about the role of technology in human error. Technology, as everyone is aware, just increasingly is coming out with new things, new advances. It's phenomenal what all the different technology can do. It's resulted in a shift of the type of work that employees do, healthcare professionals do. It also, though, can result in some unforeseen situations, such as automation makes systems more opaque. And by opaque, meaning that what I mean by that is that processes that are automated are less visible because machines intervene between the person and the task. Automation means that people have less hands-on contact with processes and are elevated to more supervisory and planning tasks. Direct information is sometimes then filtered through a machine or a computer, and operators run the risk of having too much information to interpret or not getting the right information at all. And we'll talk a little bit more about this too when we talk about the aviation industry. And I'll just share with you just a historical tidbit, and it goes back to some early work that the human factors folks were involved with, actually going back to the Vietnam War with some of the aircraft. We had the most sophisticated aircraft in the entire world, but yet we're getting shot down. And what human factors people did in talking with pilots realized that a lot of pilots were so confused by all the information that was being presented to them that they weren't focusing on actually flying the plane and doing the battle in the sky. And consequently, they ended up turning off a lot of technology that was providing information that really wasn't crucial and actually increased the performance of the pilots. And today, with a lot of the technology that has been developed, there are so many things that it can do, but in some cases that information is really information overload and not providing the critical information that is needed, or in a way that allows the user to know what information is critical for that situation. So automation can make a system opaque. You also have other issues involved with it, and that's the over-reliance on the accuracy of the technology. It's the old saying of garbage in, garbage out, or that a technical device can be extremely precise but may not be accurate. And that is a situation that can occur without somebody really understanding what is going on with a piece of technology. Consequently, the results of the increased use of technology is that more training is needed, higher level of skill sets are needed by employees, and they must be able to interpret whether the results make sense or not, and not just to rely totally on whatever number comes out of the machine. Okay, let's talk about the types of medical errors. We're going to talk about the two here are active and latent errors. Latent errors they tend to be removed from the direct control of the operator. It could result from poor design, faulty maintenance, bad management decisions, poor structured organizations. So it's generally removed from the direct contact of that team that is working with the patient, where the active errors generally are more recognizable as being directly related to the interrelationship between the patient and the specific individual providing the service. Latent errors, though, pose the greatest threat to safety in a complex system because they are often unrecognized and have the capacity to result in multiple types of active errors. Current responses to errors tend to focus on the active errors by punishing individuals, retraining, or other responses aimed at preventing reoccurrence of the active error itself. Because large system failures represent latent failures coming together in unexpected ways, they appear to be unique in retrospect. However, since the same mix of factors is unlikely to occur again, efforts to prevent specific active errors are not likely to make the system any safer itself. So and to give you an example, on many cases that we get involved with, one of the questions that we are asked is that, well, hundreds or even thousands of people have performed a specific task and nothing has happened. So consequently, this task must be safe, and this must just be a unique situation that occurred. When in reality, the hazard could have been there all along, but it was latent in that nobody recognized it, and it was sitting there waiting for the right situation to occur, which resulted then in the unsafe act and the medical error to occur itself. So it does not mean just because there have not been a lot of incidents occurring that a hazard has not been in the system itself waiting for the right situation to occur. That's what makes latent errors so difficult in some cases to identify. Okay, two other types of medical errors are errors of omission and errors of commission. Errors of omission result in an inappropriate increased risk of disease-related adverse events resulting from receiving too little treatment. Errors of commission is a medical error resulting in an inappropriate increased risk of adverse events from receiving too much or hazardous treatment. A 2005 study indicated that 95.7% of errors classified as underuse compared to 4.3% as overuse or misuse. Give you some idea of the relationship between commission and omission type errors. Let's talk a little bit now about systems. In healthcare, a system could be an integrated delivery system, a centrally owned multi-hospital system, a virtual system comprised of many different partners over a wide geographical area. Systems can mean a lot of different things, whether you're talking about microsystem or the macro system. However, any element in a system probably belongs to multiple systems. For example, an operating room is part of a surgical department, which is part of a hospital, which is part of a larger healthcare delivery system. So the variable size, scope, and membership of systems makes them difficult to analyze and understand unless you can get involved with looking at how the overall structure and organization has been laid out. Systems analysis is creating a safer systems that are designed by taking into consideration characteristics of how people use machines to interact with each other in teams. Safer systems could have been designed by taking into consideration characteristics of how people use machines. Some examples of this would include redesign the device to default to a safe mode, reduce the difficulties of using multiple devices simultaneously, minimize the variety of equipment models purchased, implement clear procedures for checking equipment, supplies prior to beginning surgery. Other examples, orient and train new staff with the team with which they will work, and we'll talk a little bit more about that later, why that's so important. Provide a supportive environment for identifying and communicating about errors or organizational learning and change to prevent errors. So now let's go into what is human factors. Human factors is the study of the interrelationship between humans, the tools they use, and the environment in which they live and work. A human factors approach is used to understand where and why systems or processes break down. This approach examines process of error looking at causes, circumstances, conditions, associated procedures, devices, and other factors connected with the event. Studying human performance can result in the creation of safer systems and the reduction of conditions that lead to errors. Just want to talk a little bit about a couple of different human factors approaches. One of them is the critical incident analysis. Critical incident analysis examines a significant or pivotal occurrence to understand where the system broke down, why the incident occurred, and the circumstances surrounding the incident itself. You analyze critical incidents, whether or not the event actually leads to a bad outcome, provides an understanding of the conditions that produced an actual error or the risk of error and contributing factors. Another one is the naturalistic decision making. This approach examines the way people make decisions in their natural work setting as opposed to being in a laboratory setting. This actually considers all the factors that are typically controlled in a laboratory, such as time pressure, noise, and other distractions, insufficient information, competing goals. And in this method, you go out with workers such as nurses, then you observe them in practice and then walk them through to reconstruct various incidents. The analysis uncovers the factors weighted and the processes used in making decisions when faced with ambiguous information under time pressure. Let's talk just a little bit about other industries and what can be learned. I just want to really touch on the aviation industry. I mentioned it earlier, and I am a pilot myself and have flown for many years. And one of the things that is very obvious when you start looking at aviation is the use of checklists. Regardless of how many hours, how many years of experience, pilots always use checklists going through the start of the flight and even the shutdown at the end of a flight. And just about every situation that is conceivable has a checklist to go through. It provides a way where you don't have to try to memorize. It also allows for good teamwork as far as checklists and the interrelationship between, in aviation, a pilot and a co-pilot. The checklist is something that could easily be incorporated within a healthcare profession. Others I'll just touch on in manufacturing, where you have such quality control methods that were developed, Six Sigma, Q1, ISO, and other industrial engineering quality programs. In the logistics industry, you can think of UPS, and you can just compare what UPS does versus the U.S. Postal Service in tracking from port to port, time motion studies that are very detailed, and looking at every little event that occurs throughout the tracking of that package and how to make sure that that package gets to the right place. Within the financial services, obviously there's a lot of documentation, verify, you confirm, and the client signs off on everything. And then within the retail industry, you have UPC codes, RFID tracking, real-time inventory ordering. And the idea is that not all of these are directly attributable to or can be used within the healthcare industry, but there are things that are used in other industries that can be gleaned and adapted and help to improve quality, reduce injuries, reduce medical errors within the healthcare profession. Okay. This would be a good time to have some questions. Looks like one of the questions, Matt, are you there?
Yes, I am.
One of the questions that Michael Neff asked is too esoteric, need some specific examples of hazard. Hazard as far as within a medical facility, we can talk about all levels of hazards and anything ranging from slips and falls within a patient room or even in the hallway, which would be a very, very basic, simple, gets involved with maintenance issues and when the floors are cleaned and scrubbed, as well as involved with the patient's room of looking at cables, hoses, things that run across the floor in the patient's room that could actually be in a slip and fall situation. Not only could somebody get injured, but also could be critical to the life of the patient that's in the room.
This is Mark. I can give, I've worked in the hospital setting. I've also I'm currently consulting with several hospitals and private practices and provide testimony and litigation services regarding medical error as well. Just a few examples that I can kind of bring to the table include in the operating room having proper policies and procedures set up, same as where cords and power outlets that are providing power to critical equipment are actually, I've seen them pulled out of the wall sockets and tripped over and such. I've also been involved in a litigation case in which an individual has rolled off of a radiology table and suffered a DINS fracture, which is C1, C2, ended up with paralysis. And there were multiple errors that occurred there, errors of omission and commission, in which policies and procedures were looked at, proper training of individuals, where simple using guards could have eliminated that hazard all completely, and the hospital's response was that they should have learned that in school. And they had no policies and procedures with how patients were transferred to and from the table. The patient was left by themselves. There was no policy and procedure regarding that. When the individual fell and suffered the DINS fracture, the individual was picked up under the shoulders without a neck brace, transferred back up to the table, so improper transfer technique. Additionally, then, the individual actually went in and had a CAT scan done to look at the brain injury, but no one examined his neck, and it was not observed until 14 days later that he actually, 14 hours later, that he actually suffered a broken neck or a DINS fracture. So there are multiple errors there where it's administrative errors, but also policies and procedures, and proper training. I've also examined medical equipment in which is utilized where warning systems aren't able to differentiate. Nurses aren't able to differentiate between the different warning systems easily. The displays are too high where they can't be read by a normal height individual, where the light shines off them. So there are many different types of situations in which can lead to medical error, which is design of equipment, policy procedures, training. A very simple example are medical beds. Many nurses, when medical beds are purchased by hospitals, these days they have many features which allow patients to be stood upright, to be rolled, assist in rolling, those types of things. However, many nurses aren't trained in the use of these beds, and so they're purchasing these very high-dollar beds without instruction on how to use them other than the simple how to tilt the person up from a flat position. And so something just as very simple as that can lead to growth error.
Okay, great. We have another question here, which is more of a situational question submitted by Michael that asks, this involves a CT scan, it looks like. The nurses thought the surgeon would order a CT. The surgeon thought the rehab doctor would order the CT, and the rehab doctor thought someone else would do it. Does this lack of communication invoke human factors?
Absolutely. That is human factors to the max right there, actually. All elements. Communication is a key element in human factors and system design. And when the system is not designed properly with the proper communication and documentation factors included, it leads to error. That's a perfect example of a breakdown of a system. One key thing that I think we could bring up here is, you know, especially in the medical field, one thing we need to start doing is important to emphasize that adopting a system approach to error reduction in healthcare requires a shift from blaming the individuals, the physicians, the therapists, the nurses, for errors, and shifting that to analyzing the system and uncovering the design flaws in the system. If the system is designed properly, the healthcare professionals aren't put in a position where error is an option, or error is minimized at least. And so I think that's the key to this is looking at it from a systems approach and designing in those checklists, those policies, procedures, to where error is not an option. And if you look at other industries, that's exactly what has been done. Error has been designed out using principles of human factors and ergonomics.
Okay, great. We have another question here from Ken who asks, do you advocate a quote-unquote policy as a prudent thing? It documents a pure standard of care versus the professional's training and judgment.
Matt, could you repeat that?
This question comes from Ken who asks, do you advocate a quote-unquote policy as a prudent thing? It documents a pure standard of care versus the professional's training and judgment.
Well, I think that any system, and we'll talk about this in a little bit, that and one of the reasons that you cannot directly take things from industry into the healthcare situation is that, you know, the human being has quite a bit of variability, and each situation does have some unique elements to it and needs to be interpreted and decisions made. However, when you start to look at a lot of the medical errors, they can be prevented by having good policies and procedures in place so that the decisions that have to be made are appropriate decisions based off of the skill set of the person who's being asked to make those decisions, and that you eliminate as much of the error that is routine or latent, as we talked about earlier, and get those critical decisions that do require human interaction that deals with the unique situation to the forefront so that the person has time and the energy to make that decision based off as much information that they can get at the time. So it's similar to what we call risk management, where you're actually looking at the risks and benefits and managing that and getting the time necessary to make those appropriate decisions.
This also will go into a little bit of evidence-based healthcare, which we'll talk about here in a few slides, where decisions are made based upon research and outcomes as opposed to because that's the way it's always been done. And there's actually a lot of that in medicine, just in the way that physicians are trained in residency, learning from other physicians. There's a lot of, I've always done it this way, this is why we do it, as opposed to really looking at the research behind why we do it, what the outcomes are, and what is the best protocol for what we're trying to resolve.
Great. It looks like we have one more question, and then we'll move on to the presentation of content. John asks, Is it latent error for an operative surgeon to rely on the opinion of the radiologist without personally reviewing the X-ray? This involves a missing surgical sponge post-surgery.
So does the question have to do that there was a surgical sponge left and that the radiologist should have picked that up on the X-ray?
I believe so, yes. John, if you're listening, if you could clarify if that sponge was, I guess, in the person, that would be helpful. But I guess what he's asking is the operative surgeon did not review the X-ray and relied on the radiologist to find a missing surgical sponge post-surgery.
This gets back to I'll answer the question in two parts. One is from the standpoint that it gets back to having policies and procedures of exactly the responsibilities and accountability of the radiologist. If the radiologist's responsibility includes not only looking at specific diseases or analysis of the X-ray, but goes beyond and looks at counting for various foreign bodies, foreign objects in the body, then the physician question disappeared. But then the physician or the surgeon would not need to be the one to review the X-ray. However, if the radiologist does not have that accountability and responsibility and is told to do that in policies and procedures, somebody has to, whether it's counting before the patient is closed up at the end of the surgery, which is typical where you count all your sponges and count all of your tools. So it would just depend on, again, back to policies and procedures. I'll let Mark talk a little bit about the latent.
Yeah, well, I think that to piggyback on what Will said, rarely an error occurs because of one instance. It's typically the multiple things that lead to a catastrophic error, and this is why you have redundancy built into systems, such as what Will mentioned. Checking with radiology, looking at the film, but also counting the sponges. And in a properly designed system, that redundancy would bring light to the error that occurred due to the radiologist misreading the film or whatever the case, or the physician miscounting the sponges. So I think the thing to keep in mind is typically you're not looking at a single event causing a catastrophic error, but it's multiple events that lead to it.
And so consequently, if they don't have policies and procedures, it would be a latent error that is waiting to occur in this situation.
Okay, let's continue on with the presentation of content, and then we'll get to the questions that are in the queue during the next Q&A break.
Okay, and we're going to, just due to time, we're going to go through this next section a little quicker. This first slide really is just to show you the kind of the progression since '95 of various patient safety movements. One of them we're going to talk about is one that occurred in 2006, and that's this one here. It's the AHRQ called Team Steps. And the reason that we're going to talk about this one is that the AHRQ is the Agency for Healthcare Research and Quality, which is actually an outgrowth for patient safety from the Department of Health and Human Services. So it's a very good overview of all the elements, strategies, and tools to enhance performance and patient safety. And it's called Team Steps. So we'll kind of use that as one of the models here to walk through. Talk a little bit here about error reporting. Between 1999 and 2004, U.S. Congress introduced a total of 10 patient safety bills, with 9 of those containing language ensuring some degree of protection for those institutions reporting medical errors. However, all of these bills were blocked. It wasn't until 2005 that there was a Patient Safety and Quality Improvement Act requiring the Department of Health and Human Services to establish a process for voluntary and confidential reporting of medical errors. Today, there are 27 states that adopted mandatory reporting and 23 states that maintain voluntary reporting. So as you can see, the debate between voluntary versus mandatory continues on even today. This is another model called the Shell model, and we won't go into a lot of detail here, but other than to say that the Shell model outlines the contributions to errors in microsystems. So this is really looking at, in healthcare would be like the operating room, the emergency room, as opposed to the entire organizational structure or macro system that we were talking about earlier. In this case, when the L is liveware, and that has to do with, obviously, the patient and the medical care provider and the interrelationship between them. The liveware also is interacting with the environment, and the environment could include the emergency room, the operating room, but also political, cultural, and financial factors can play a part because they can put outside pressure on decision-making that is made by the healthcare facility and contributing to the latent failures in the system that we talked about earlier. Could also include noise, overcrowding, irate patients, frequent interruptions, things like that. H is the hardware. Hardware can include not just the technology, but also the medical devices, but also the instruments used by the healthcare provider. And then software includes more than just the computer software, but also includes procedures, manuals, checklists, anything that could go into that's more soft as opposed to the hard goods themselves. Components of a patient care team. Obviously, as you get closer to the top of the pyramid, that's where the focus is on the patient, and the core team itself is the group that has direct contact with the patient. And then obviously as you go down the pyramid, you have the coordinating team, ancillary support services, and the administration. And again, because of time, we don't really have a lot of time to go through this, but the components of a patient care team can be visualized as a pyramid. Errors in this area are often active errors, and their impact is immediately noticed. As you move towards the bottom of the pyramid, there's less direct patient care involved. These components can contribute to latent errors in the system, which may combine over time to cause an active error. Strong teamwork and coordination between the components act together to reduce opportunities for errors and ensure quality patient care. One of the key things here we put here is the ratio of we's to I's in any kind of a team. Teams work best when you start to hear them act and function like a team by using the words we versus I. And again, some of the key principles of an effective patient care team that we would look at the leadership. We would look at situation monitoring, mutual support, how well do they work together, supporting each other, and then communication. It seems like a lot of the questions that we're getting has to do with communication. Effective communication requires the ability to clearly and accurately exchange information amongst team members. The importance of communication cannot be overemphasized. The 10-year study carried out by the Joint Commission identified failures in communication as the root cause of approximately 66% of reported errors. So as you can see, based off of what the questions are today and the research, seems to support that also. Communication is a critical element of an effective team. Obviously, the outcomes that you're trying to get is team performance, team knowledge, and positive attitudes. Let's talk a little bit here about barriers to effective patient care team. The one that I'd like to spend time with is the inconsistency in team membership. One of the things that takes time is developing a team, and it doesn't matter whether it's a football team or a patient care team or a team at an industrial setting. It takes time for people to get to know each other, feel comfortable with each other, to know each other's strengths and weaknesses, and for a team to develop that rapport that is necessary for a team to function effectively, especially in a high-pressure, critical situation where time is of the utmost importance in making an appropriate decision. And so one of the areas that we really look at is the consistency in the team membership. Do they work together often? Do they rotate to various teams? How do they bring new members into that team to understand how the team operates? All the elements that goes into team membership. It's just an absolute critical area, and inconsistency can lead to a very strong barrier to an effective patient care team. Okay, tools and strategies to overcome those barriers. There's just a couple here that I bolded in red that I just wanted to briefly mention. One is, it's called a debrief, and oftentimes when there is no issue involved with a procedure or a process, nobody stops to analyze why it went well, or were there things that could still be improved even if there wasn't an error involved in the process. So we recommend a debrief that includes recounting the events that occurred to analyze what worked, what didn't, discussion of the lessons learned, how they will impact the future plans, and establishment of a method to formally change the plan to incorporate those lessons. And this gets back to closing the loop, a closed loop process where we continually are improving the process based off of the information and input of the team members each time that they do that specific task or event. The other is the two-challenge rule. One of the biggest challenges in the healthcare profession is getting somebody to basically speak out when they don't agree with a decision that is being made. And so the two-challenge rule was developed to prevent disasters when otherwise excellent decision makers experience a momentary lapse in judgment. Team members should voice their concern at least twice if the initial assertion is ignored. The first challenge should be in the form of a question, and the second should provide support for your concern. So again, it's really allow those people who have an issue to speak up and not feel like that they're intimidated within a team setting. And again, it gets back to what I had mentioned on the earlier slide, having to do with the ability to know your team, trust your team members, and being able to speak up because you're a valuable member of that team itself.
Evidence-based medicine is a relatively new development in healthcare, and it utilizes the current best evidence in the decision-making process for patient care. The practice uses individual clinical expertise along with the current best evidence available regarding medical treatment. Utilization of up-to-date research provides the physician and patient relevant information such as the effects of different forms of healthcare, the potential harm from exposure to particular agents, the accuracy of diagnostic tests, and the predictive power of prognostic factors. The Joint Commission has begun incorporating an evidence-based framework as part of the accountability measures to improve patient outcomes in hospitals. Hospitals performing well are those that consistently provide evidence-based treatments, practices demonstrated by scientific evidence to lead to the best patient outcomes.
Okay, how patients can take control. So far we've talked about the system itself and we put the patient at the center, but we haven't really talked at all about the patient's responsibility into this process also. And I want to talk just a little bit about the very first point here, and that is for a patient to be an active member of the healthcare team. It is the patient's health and it's the patient's life And we feel strongly that you don't abdicate your responsibility to the healthcare system with your fingers crossed hoping for the best. The ultimate decision and the final decision in many cases rests with the patient. However, obviously the patient is not the one that's been trained in all the healthcare procedures and policies, and you have to rely on the hospital, but it doesn't mean that the patient doesn't have some responsibility in this process too. And again, just wanted to point out a couple of points here. Number 18, know that more is not always better. One of the things that we debate and discuss here a lot is does the use of additional testing reduce the amount of medical errors? And we feel very strongly that those organizations that tend to use a lot more processes or procedures introduces the opportunity for more medical errors than actually to reduce the medical errors, because they probably are not practicing evidence-based medicine and probably are more likely to have latent errors within their system, that the more processes or procedures that are performed increases the opportunity for medical injury and medical errors within the system itself. And then lastly, for the patient, if you have a test, don't assume that no news is good news. And it kind of gets back to the question that one of the people had asked earlier, having to do with patient information. And just because you don't hear doesn't mean that it's good news or bad news. The patient needs to follow up and to make sure that the test results have come back, and that the information is adequately discussed with them with the healthcare provider. All right, that gets us here where we have just a few minutes for a few more questions.
Okay, great. Thanks, guys. We do have a question here that was a holdover from the very end of the last Q&A break. It's an issue of standard of care. Are you familiar with the policies and procedures used by hospitals to address pressure sores from developing with patients of large size and or who are subject to medically induced coma? Where can such information be located?
Pressure sores are a big concern with bariatric patients as well as with the elderly. Specific, I guess, are there specific policies? There are general policies and procedures that that are used for the there are policies and procedures that are used to help reduce the likelihood of developing pressure sores. I can't rattle those off the top of my head, but I am familiar with those. I'm not sure at what level those have been policies and procedures, more at the hospital level, not at a federal level. I'm not sure if that's what's being asked or not.
As well as for medically induced coma, we'd have to look into that and see. Obviously, for that specific situation, that's a pretty narrow.
Yeah, obviously with a medical induced coma, you're going to have an individual that's not going to be moving themselves, and so they are going to have to be moved and rotated frequently. That's where bed use comes in, and properly positioning of the bed and such to help reduce pressure points on patients.
Okay, great. I don't see any other questions in the queue. So if there are attendees out there who have questions, we will stay on the line for a couple more minutes. But Will and Mark, if you have any summarizing remarks, please, feel free to use this time now to kind of summarize your presentation.
Again, we just appreciate the opportunity. We know that this is done at a very high level from like the 40,000-foot levels, we call it, and that implementing a human factors system approach gets involved with all levels, such as what we talked about earlier, from such little issues, slip and falls, all the way up to organizational design, policies, and procedures. And so through a systems approach, we're able to identify the root cause of the medical error within the system itself.
One element that we didn't really touch on that definitely is related to this is pharmaceutical error and proper dispensing of drugs, proper dosage, those types of things. And that obviously falls right into the human factors element as well. There are machines and policies, procedures, processes that can be used to help reduce those risks and result of error and harm to patients.
Thanks again, Matt.
Okay, great. Well, thank you guys, and thank you for spending the time putting together a great presentation. I'm just going to wrap things up here very briefly. Again, I'd like to thank Will and Mark for this time in putting together the presentation, and I'd like to thank all the attendees who took time out of your busy schedule to spend an hour with us today talking about medical errors and human factors. If you'd like to speak to William Nelson or Mark Heidebrecht about a specific case or project, you can contact us here at TASA. Our telephone number is 800-523-2319. We'll be sending out a link to the archive recording of this webinar tomorrow morning. The archive recording will also be posted in the Knowledge Center of TASA's website. If you go to our homepage, tasanet.com, and to the top navigation bar, you see a link to the Knowledge Center. You can click there and then click on the Webinars tab to get to all of the webinars that we posted over the last 18 months. If you have any follow-up questions or comments, we're always looking for constructive comments on how these programs can be improved. Please email me at mhyde@tasanet.com. You will be receiving an email from me at 3:30 this afternoon thanking you for attending and giving you some brief follow-up. And then we'll send out another email tomorrow morning when the archive recording video is available. Please feel free to share this information with any of your colleagues and or peers. Again, thank you for your time, and we look forward to seeing you at future TASA events.